Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you very much, and thanks for inviting me. So I'm going to talk about M. genitalium today because it is a big, interesting topic with a lot of new research. So here are my disclosures, nothing related to this work. Some related to my gonorrhea research, but nothing on the M-Gen side. Here is the disclaimer slide. And just a real quick highlight before I get into the nitty-gritty of M. genitalium about how it sort of connects to HIV. So I'm going to talk about sort of various syndromes that are related to M-Gen, the urogenital tract and reproductive, particularly in women, but there's also an association between HIV and M. genitalium, kind of like with chlamydia and gonorrhea, other bacterial STIs. So prior M-Gen infection has been associated with HIV acquisition, and there was a meta-analysis some time ago that showed a summary odds of a twofold increased risk of HIV infection in those people that have M-Gen. Also, similar to what we've noted in gonorrhea and chlamydia, there's also an increased risk of HIV shedding shown in these three studies. So very closely related, likely due to the inflammation it causes in urogenital tract. So now that I've given you that one bit of information, I'll talk a little bit more about what M. genitalium is itself. So I feel like this is a very fall-themed shaped organism. It looks like a gourd. If you want more information about the specifics of this very tiny bacteria, you can go to the PTC CDC Prevention Training Center homepage, click on M-Gen, and it will give you an overview. These are some interesting figures just of the organism itself. It is a very tiny organism that lacks a cell wall. So sort of like chlamydia, you can't see it on gram stain, and it needs to be identified mainly by molecular testing. It has, interestingly, one of the smallest genomes of any living thing and is studied by people to look at the minimum requirement for life. It's extremely fastidious and slow growing, and so culture is only accomplished by a few laboratories in the world, including Gwen Wood's lab here at University of Washington. So it needs a very complex growth media, or it depends on the host for most of its nutrients. So highly associated with the human host, as are many of the STIs we see. So a little bit about epidemiology. How common is it? So these are some earlier, more historic studies that are at a larger population level of persons not necessarily at risk. And they've shown 1 to 3% of people being infected. We can compare this to chlamydia and gonorrhea, where it's sort of somewhere in between the prevalence of these two other bacterial STIs. There was a great recent study looking more into M. genitalium epidemiology done at several sexual health clinics around the United States. And again, this is at people who are more at risk, sexually active young adults attending STI clinics, and just doing surveillance urogenital testing on specimens that were obtained from people. Found that around 1 in 6 persons had a positive test for M-Gen, and these were symptomatic and asymptomatic people. These are the sites across the United States, so includes one here in Washington. And the prevalence was shown to be about the same between people with a cervix and people with a penis. So really similar prevalence as opposed to some of the older studies that had showed a higher prevalence in women. As you might expect, there was a higher prevalence of M-Gen within the MyGenius study in folks who were symptomatic, but there was also an equally high proportion of folks who are asymptomatic who had M-Gen. So really can exist in this asymptomatic state in lots of folks. It was highest in younger people attending these clinics, kind of similar to the historic data. And interestingly, higher prevalence in heterosexual patients compared to those with same-sex partners. Now that I've given you a little bit of information about epidemiology, I'll talk about the data about related syndromes. So Really, the syndrome that has been most highly associated with M. genitalium and has the most data behind it is penile urethritis. So, in about 15% of all urethritis that we see is due to MGen. And if you look just in urethritis not due to chlamydia or gonorrhea, it's even a higher proportion, about a quarter. So, the summary odds ratio for having MGen, if you have acute urethritis, is here. And it's even higher likelihood that MGen is implicated in people who present with persistent urethritis. And this is likely because a lot of the treatments that we give commonly for chlamydia and gonorrhea up front don't treat M. genitalium, particularly now in the case that there's more azithromycin resistance in MGen. And I'll talk a little bit more about that later. So something to definitely keep in mind in your urethritis cases that you see in clinic. There's also general agreement about the association with pelvic inflammatory disease. There was a more recent meta-analysis that I'll touch on briefly that corroborated this data, showing that there is a strong relationship between M. genitalium and pelvic inflammatory disease. So 4 to 22% of women with PID will have M. genitalium, and your odds of having M. genitalium are around 3.5 if you present with PID. Interestingly, all of these associations with these syndromes are higher when they control for chlamydia, sort of indicating that this may actually be the underlying etiology that we observe in this compiled data. This recent meta-analysis looking at pelvic inflammatory disease shows that about 1 in 10 women with PID have M. genitalium, and the newer studies also show higher odds ratio of having MGen in women with PID, and this is slightly narrower than the odds ratio from the prior meta-analysis, but really corroborating findings. So I think that there's great data that urethritis is caused by MGen. I think there's more and more data about PID and other syndromes in people with the cervix. And this sort of makes biologic sense. These are pictures of fallopian tube culture looking at treatment with both chlamydia, where we see this characteristic blunting of the hair follicle cells. And you can see some of this as well with M. genitalium. There's also in vitro studies that have looked at cell culture and induction of inflammatory response. These are the other syndromes. Just in the interest of time, I wasn't able to go over everything, but these are the other syndromes associated with MGen in women. I would say cervicitis also has mounting and good data behind it. The data associating M. genitalium with birth outcomes and infertility is less robust because these are really hard outcomes to study, and that the exposure is often remote from the outcome, but I think that there's good biologic basis for this. However, screening is not recommended in these groups due to lack of evidence as well as lack of treatment options. So here you can sort of see a summary risk increase with these syndromes in women as a sort of all pooled data together, and an even higher risk increase in people with MGU. So after going over the possible syndromes that could be associated with MGen, I'm going to talk a little bit about testing. So who should be tested? And it's a little bit circular who should be tested and like our treatment options, because I think they go hand in hand, and that we don't really have a lot of great treatment options for folks, which I think has limited our extrapolation of the data to inform broader testing. That's my own personal opinion, but these are the CDC's current recommendations. So they, by and large, or just generally, do not recommend screening asymptomatic people for prevention of disease. So any of those sequelae that I mentioned associated with MGen, CDC does not recommend screening anyone to prevent these sequelae. However, diagnostic testing is recommended in people who are symptomatic. So currently, the CDC recommends testing men with persistent or recurrent urethritis for MGen and women with persistent or recurrent cervicitis, as well as a consideration for women with pelvic inflammatory disease. I would say in my own practice and in the clinic where I practice, our sexual health clinic, we have started testing men up front who have urethritis for MGen, because we do see a high proportion that have only MGen and that need treatment, and it sort of expedites their getting their appropriate treatment. And also similarly, I think folks are moving towards testing people, at least with pelvic inflammatory disease up front, if not with cervicitis, although we see that less commonly. One of the reasons to test upfront pelvic inflammatory disease is because the treatment would slightly differ if you knew you had an genitalium. Also true for urethritis as well. We have several FDA-approved diagnostics. There's a third one that has been added to this list that I haven't put on this table just because it came out later. But you can see generally the test types that you want to obtain are vaginal swabs and male urine or a urethral swab if you're doing a urethral swab for urethritis anyway. These are the most sensitive and specific with all of the tests that are available. And you can see sort of the range of other sensitivity and specificity here. Female urine tends to be less sensitive than the vaginal swab. Moving right along to treatment. So treatment for MGen is a bit more difficult and nuanced than, say, for chlamydia or gonorrhea. And this is informed by the fact that there's kind of like gonorrhea, MGen, any antibiotic you expose it to, it's going to mount resistance against. So currently, the recommendations are divided by whether or not you have resistance testing, molecular resistance testing available. This is very common in European and other areas, Europe, Australia, where you can test for macrolide resistance as well as some places for fluoroquinolone resistance, but we by and large do not have this. So really most folks, including here at UW where I practice, we're really going to be basing this on the recommended regimen if there's no resistance testing. And that is to give doxycycline up front for a week, followed by moxifloxacin. And so if you have someone with urethritis who's coming in and you're empirically sort of treating them for chlamydia, you'll be already starting the M-genitalium treatment. And then if you know they actually have MGen rather than chlamydia, you can then follow it by your 7 days of moxie. And this is also what is advised for cervicitis. PID, which I won't touch on here, basically, the caveat is that standard PID regimens are not very effective against MGen, so you will need to make sure you use something that includes moxifloxacin if you know a person with PID has MGen. The reason we've moved away from azithromycin in the absence of resistance testing is that over time, we've showed that azithromycin or just doxy alone has become less and less effective. This really started happening in 2009 when you could see sort of a trend towards more than half treatment failures when using this azithromycin alone. These are just the rates of azithromycin resistance across the United States. These are a bit old, so it's even higher in some places now, but mainly upwards of 50%. This figure illustrates azithromycin resistance in the blue bars at STI clinics in men presenting with penile urethritis, and then concurrent quinolone resistance. So you can see quinolone resistance, moxifloxacin being one of them, is lower than azithromycin, which is why we base our empiric treatment on moxifloxacin now. This is a great review that came out recently, and we'll review all of the topics that I've touched on today, but also has a really great chart for treatment based on either if you have resistance testing or if you don't. So mainly you'll go down this side of the algorithm. If you suspect MG infection or you have someone with a syndrome, make sure that you include doxy in it. And then if you have an MGen positive NAT, resistance testing is not available, you're going to treat with moxie. I mainly included this chart not because I think some people will have resistance testing, but I think this is a great review if I've whetted your appetite for MGen and you would like to read more. The one thing I will say about the doxy, if anyone is wondering, is the reason we give it up front, even though it's not very effective as a single agent, only curate of around 30 to 40%, it does decrease the bacterial load of MGen significantly. And there have been studies that have shown sequential therapy like this decreases the propagation of resistance to the second agent you add. So doxy sort of decreases the burden of MGen around, and then the moxie goes in and mops up the rest. that would not have otherwise been cleared by the doxycycline. In the last few minutes, I'm just going to go over some key points, and I've also included these just so that people have a little bit more information than I was able to fit in today. But in summary, what we know, MGen prevalence is higher than gonorrhea and sometimes higher than chlamydia, depending on your population. It elicits an inflammatory response and causes tubal damage in vitro. Most genital tract symptoms are associated with MGen. However, some have higher quality evidence than others, and antibiotic resistance rises rapidly when we introduce a new agent to treat it, or when we just give people an agent to treat something else. What we still don't know, how frequently MGen results in PID and infertility, and can early detection and treatment prevent these sequelae in women, and what are the implications of asymptomatic infection? What should you do if you suspect a patient has MGen? Order a test. There are multiple FDA-approved tests. Resistance testing is not available in the US, but there are studies ongoing, so I'm hoping that may be available sometime in the relatively near future. Empiric treatment for non-pregnant patients, doxycycline, 1 week followed by moxie. This is empiric. Encourage patients to return if symptoms recur. This is sort of outside the scope of this talk, but if you suspect a failure, you can try minocycline. There's some data that tinidazole may be effective, and also a plug for our expert consultation if you suspect an MGen failure for the Prevention Training Center. We get a lot of questions about MGen, and it often is a case-by-case consideration. Infection is most common in women less than 25. Screening asymptomatic patients is not recommended. Did not touch on this, but treatment in pregnancy is very challenging, as you might imagine, because moxifloxacin is a Class C drug during pregnancy, and doxycycline is not given to pregnant women. For teratogenicity concerns, there's ongoing discussion about all of these things, but currently high doses of azithromycin is what is suggested, which, as you might imagine, is not as effective as we would like. Test of cure is only recommended in those treated with azithromycin, such as pregnant people, in the absence of knowing resistance testing, and not for people whose symptoms have just resolved or as a matter of standard course. Include moxifloxacin in PID if you know there is genitalium. The other treatments do not treat it well. And ongoing sex partners should be tested and treated with the same regimen as partner, and presumptive treatment only when testing is not possible. So conversely to gonorrhea and chlamydia, where we still do a lot of empiric treatment, we really test and treat people for MGen, mainly because of the treatment option limitations.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.